a minute before, oh, here we go. Welcome, my name is Becky Sanders, and I am the Program Director for the Upper Midwest Telehealth Resource Center. Thank you for joining us today. We are recording today's session, and we will make the slides available on the UMTRC archived webinars page. You'll get that information via email just in a couple of days, and once we get it all posted. And today it is my extreme pleasure to introduce to you Nancy Kazak, who is going to lead our panel today. Nancy and I have worked together for a very long time with her efforts for the Partnership for a Connected Illinois and broadbandillinois.org. Just one other thing I wanted to mention before we get started is in your Zoom window for this webinar, you have a couple of different options across the bottom of your screen. We want you to use the Q&A button. If you have any questions, we'll ask for questions, I believe, at the end of each panel. And if you have technical issues, then use the chat. We ask you to use the Q&A so that we can record the questions, and just in case we don't get to all of them, that we can address those afterwards. And you are all in listen-only mode. Again, we will be recording today's session. We will send out that recording to everyone who registered. And also with CME and CNE, we're working on those, and those will be sent at the end as well based on our registration records. All right, Nancy, without further ado, I'm going to turn everything over to you.
Thank you, Becky. This is Nancy Kazak. I'm director of the Illinois Telehealth Initiative, which is a project of the Partnership for Connected Illinois. And we have been, over the last 5-6 years, holding informational forums so people can learn more about telehealth. And during the COVID pandemic, we have been holding a whole series of virtual forums. And today we're very excited to hold a virtual forum on using telehealth in long-term healthcare facilities during the fight against COVID and its aftermath. I want to thank, in particular, the Upper Midwest Telehealth Resource Center, who is co-hosting this event for us today. We couldn't have done it without you today, or for the last 5 or 6 years that I've been working on this stuff. And I also want to thank our other co-host, Prangle+Schoonveld, the firm, Ann Ford, who's a partner on it, and there will be other representatives of the firm throughout the program. They have hosted this and have put this extraordinary program together, and Ann has just done a terrific job, and we're just really very, very thankful. I want to thank also the supporting nonprofit organizations. We've had 5 organizations that have helped us promote this event and recruit people to attend and to participate. The Chicagoland Healthcare Risk Management Society, CHARMS, the eHealth Initiative, the Illinois Association of Healthcare Attorneys, the Illinois Primary Healthcare Association, and the Illinois Rural Health Association. We couldn't have done this without you, so thank you so much. I want to thank the speakers. We have an extraordinary group of speakers, and for taking time and sharing with us their expertise and their analysis on where do we go from here, and how telehealth can improve the quality of care that people are provided. I also want to thank all of you for attending. I appreciate your participation, look forward to your questions. But most importantly, I want to thank the frontline healthcare providers who are doing extraordinary work over this last 60 to 90 days, and our hearts and thoughts go out to you, and we look at ways that we could be making and helping you perform your care. And with that, I want to turn this over to Ann Ford. Ann and I have known each other more years than we want to admit, I think, and in various capacities. And Ann is an extraordinary person. She's a partner at Hall Prangle and director of some of their programs. And we really appreciate her involvement and her great work in putting this together. Over to you, Ann.
Nancy. I'm honored to introduce today our keynote speaker, Mr. Mark Parkinson. As many of you know, Mr. Parkinson is the current president and CEO of the American Healthcare Association, which is the premier advocacy organization for long-term care. and which represents 14,000 long-term care facilities. Mr. Parkinson's been a passionate advocate for long-term care for many, many years. He and his wife have owned multiple nursing homes until 2006 when he became the governor of Kansas, where he remained for multiple years. By virtue of his specific background and experience, Mr. Parkinson is intimately aware of the myriad issues that are facing long-term care during this pandemic and how the delivery of care to long-term care residents and patients is forever changed as a result. He has been interviewed in the national media frequently over these past few months, sharing the long-term care industry's perspective on the impact and the changes that COVID-19 has precipitated. With that, I'm going to turn it over to you, Mark. And again, I appreciate your time today.
Thanks, Ann. And good to be here with everybody this afternoon, and glad to be able to spend a few minutes with you, kind of giving you my perspective nationally. Ann had called me up and invited me to do this, and I wanted to do it. Really have great opportunity to talk with so many of you, and I've had a chance to work with Ann in the past when she was at Medline, and thrilled to help her out with this event now. And again, glad to give my perspective. If you've looked at the brochure for this event, and it had my name, and then it had a picture that looks very different than what you're seeing right now. And that's because Ann, I think there was a breakdown in our office being able to get the photo to her. So she went online and pulled off a campaign photo from 2006. And so that photo, unfortunately, does not look like me right now. I'm not one of those people that tries to hide my age. My wife and I decided long ago that we're going to try to age gracefully without surgeries or Botox or any of that kind of stuff. So the photo in 06 is like the best I could possibly have looked. That was the campaign photo. And what you're now seeing is 14 years later, after being holed up for 2.5 months, working 7 days a week. So this is, I guess the worst version of me. But at any rate, I'm happy to be here, and I am actually that guy that was in that photo at one time. The most important stuff related to COVID are the residents and how they're doing and what we're doing to help the residents. And then it's the staff and how amazing they've been and what we're doing to try to help them. My topic is actually going to be different though, but I wanted to acknowledge that those two by far take precedence over the comments that I have. I thought that what I could add the most this afternoon would just be to give you a very high level overview of how disastrous this has been to the sector and what we have to do if we're going to be able to get out of this, just with our very survival as a sector. I don't think I have to tell anybody in the audience what a challenge this has been. All of the data that is out there is correct. If anything, it's understated. We believe that there are now COVID positive patients in about 1/3 of the skilled nursing facilities across the country, that there are now over 100,000 residents that have tested positive, and that unfortunately the mortality rates that we learned from China 4 or 5 months ago have proven to be true as it relates to our population. Roughly 15 to 20% of the residents in our buildings that are catching COVID are dying. I mean, that is just the grim reality of this. It's also had a very, very difficult impact on the sector just as a business model. How do we go forward? Every building, whether it has COVID or not, has been impacted by occupancy. And that's because many buildings have put a ban on admitting new residents. And even the buildings that have not done that have been impacted because hospitals have really basically shut down. The decision that hospitals would not do elective surgeries reduced the number of discharges dramatically, and therefore started having a very negative impact on occupancy in skilled nursing facilities. On top of that, the cost side has continued to increase dramatically. The cost of PPE, if you can find it, has doubled, tripled, sometimes even more than that. And the need for staffing has increased. As we have gone to isolating residents, getting rid of communal dining, and really doing a ton of things to try to keep COVID out of our buildings, the costs have gone up dramatically. It's really ironic and unfortunate that we came into 2020 thinking that 2020 could possibly be the best year in the history of the sector because of the favorable impact of PDPM, the new payment model. Now it is clearly going to be one of, if not the worst year in history. So the question is, how do we come out of it? And I think that there are three things that we have been focused on back here in DC that we feel like we need to win on in order for the sector to come out. And the good news is we're making progress on all three. Number one, we feel like we have to create a financial bridge for providers to make it to the other side of this. Because of the devastating impact on census and on cost, if we don't get additional state and federal help, a lot of people just aren't going to make it. The good news is that we've been able to piece together a series of wins in DC that when you add them up are starting to make a difference. It's stuff like lifting the 2% sequester, so everybody got a 2% rate increase on May 1. It's getting a clean payment rule for 2021, and most important, PDPM not being impacted. It's the accelerated payments from Medicare. It's the stimulus money and the additional funds that we received from that, the waiver of the 3-day stay, the FMAP money, where some states have provided Medicaid increases, and I think most important, additional stimulus money. There's still over $100 billion left in the HHS Stimulus CARES Act account. We have been lobbying vigorously for a SNF-only payment, not a payment where we get a piece of a large amount, but instead a payment specifically for us. And Ann, I can actually announce some news, which is that we're going to win on that issue. We've had discussions with HHS today, just as recently as 15 minutes before this call started. And I think it's very possible that either today or tomorrow, HHS will be announcing a SNF-specific payment in the way that they had a specific payment to hospitals, and we should be receiving those funds possibly this week. So issue one is getting to the other side financially, and I think we're making progress there. Issue two is immunity. I know there are a number of people in the audience that are lawyers that defend facilities, and we appreciate that, and I think they would certainly echo the concern that I have and that we have, which is that this could become a litigation nightmare. I think that there are a bunch of folks in the plaintiff's world that view this as the next opioid crisis, the next asbestos or tobacco type litigation. If it ends up that way, we are in real trouble. On the factual side, the facts are actually pretty good for us. This virus developed and spread primarily because of the unfortunate fact that people could catch it and be asymptomatic. And that led to a spread, not only in general communities, but a spread within our buildings. There's nothing that we could have done about that. So the facts are pretty good for us, but the problem is, if the litigation is so pervasive as it might be, we could end up just getting crushed by litigation cost. So trying to figure out a way around that and hopefully getting immunity from the states and the federal government is extremely important. About 15 or so states have issued a form of immunity, including Illinois, and we're advocating for the rest of the states to do that as well. And we're also pushing for some immunity on the federal level. And we've got a decent shot at it. The Republicans are saying that they're not going to pass another stimulus bill without some sort of blanket immunity. So we've got a chance to win on the immunity issue. The third thing that we have to win is we just have to win back the confidence of the public. The headlines have been devastating, and the assumptions that we are at fault for this have really hurt. They've been painful to the people that have worked 60 or 70 days in a row, double shifts, but they have their impact with the public. There are a couple of really good, though, I think, favorable data points that I can share with you. One is that the academic researchers have started analyzing the difference between buildings that have COVID and don't have COVID. Dr. Grabowski from Harvard did a study, Dr. Moore from Brown separately did a study, and they independently concluded that the presence of COVID is not related to deficiency history, it's not related to the quality of the buildings, the 5-star score, none of that. Instead, the correlation is whether or not there is COVID in the general community. If you're in New York City, where a large percentage of the population have COVID, because 8 people can be asymptomatic and carry it, they're going to bring it into your buildings and you're going to have COVID. If you're in a more rural area with less COVID, you probably won't. And so there's just increasing academic evidence that I think will help us as oversight continues to verify that this isn't a matter of good buildings or bad buildings. This is just an absolutely horrible, deadly virus that was inflicted upon us. The second piece of data is some polling that we've recently done. We've been polling the public for the last 10 years to figure out what it thinks about nursing facilities, skilled nursing buildings, assisted living, and really all healthcare providers. And we were really concerned that because of the headlines, the view of nursing homes would have collapsed over the last month or two. The answer is, though, that it hasn't. We got our polling data back last week, and we were thrilled to see that the public seems to be getting this. The approval, disapproval rating of nursing homes, and in fact, all healthcare providers, has actually gone up during this crisis. And when you ask people questions like, is this the fault of nursing homes, or was this just something that happened because of the vicious nature of this virus, a clear majority understand that there's really not a lot that could have been done to keep this out of buildings. It's because of the vicious nature of the virus. And there's overwhelming support for additional state and federal aid to help us get through this. So it's going to be tough, and some people, probably won't make it. Some providers may not make it. But if we can get sufficient funding, some help on liability, and then win back the confidence of the general public, I think we have a really a good fighting chance to make it through this. I think telehealth is a super exciting topic. In fact, I gave an interview just this morning where I highlighted telehealth as one of the real pluses that had come out of this whole crisis, and I thought would flourish after it. It's been a godsend in our buildings. And so I really hope that you have a great and productive rest of the conference. And again, I appreciate the opportunity to present this information to you, and wish very much like I looked like I was in that picture 14 years ago. But even though I'm not, I'm very glad to be where I am right now, fighting for providers, staff, and residents of nursing homes across the country here in Washington, D.C. Thank you all very much.
Mark, we thank you. Thank you so much for taking time out of your very busy schedule to talk to this group. Everybody appreciates it. Thank you. All right, I'm going to turn it over now to our first panel, and April Walkup, my partner, is the moderator, and she's going to introduce her panel and take it from here.
Thanks, Anne. Good afternoon, everyone, or good morning, depending on where you are. As Anne indicated, my name is April Walkup, and I am Anne's partner at Prangle+Schoonveld. I focus my practice in primarily the corporate healthcare sectors, providing advice and counsel to a variety of both healthcare entities and healthcare providers on a whole host of regulatory and compliance issues. I have joining me today on my panel two very qualified individuals who are going to take this time now to introduce themselves as we move on to our topic, which is really going to focus primarily on reimbursement relative to telehealth in the long-term care setting. We're going to give you a brief historical perspective. We're going to talk to you about what the changes have been as a result of the federal laws, a little bit of touch on what those changes have had in the state of Illinois as it relates to the executive orders that have been entered. And then Allie is going to give us a bit of a perspective as similar to what Mr. Parkinson just provided as far as what we see coming down the pike for long-term changes.
We can't hear you.
April, you may want to call in using your phone if you're on the audio for instead.
Cheryl, I can hear you. Should we go ahead and give introductions while we wait for April?
Sure. Yeah, because April may be able to just dial in from her phone as opposed to using the equipment. Well, I'll go next and introduce myself. Okay, there's Allie. I'm Cheryl Dashow. I go by Sherry. I am I guess I don't want to say that I'm a dinosaur, but I am a healthcare lawyer. I've been practicing healthcare law for many years. I'm at the firm of Cypher Shaw, where I'm a partner. And I also have a doctorate, master's and doctorate in public health, so I have a very strong public health focus as to the issues that are now affecting us with COVID-19. And I'm going to be addressing, as April said, the early stages of reimbursement and what some of the challenges have been. Allie?
That's great. Thanks, Cheryl. Well, thank you for having me here. My name is Allie Wills. I am the Vice President of Strategy for Horizon Government Affairs. Horizon Government Affairs is a DC-based consultancy. We do advocacy, policy development, economic analysis, and coalition management, in addition to a variety of other things. We're all healthcare all the time. I personally am actually a lawyer by training, but I no longer practice in my current role, but it does inform some of our policy development and our core areas of interest. Health Innovation Alliance is one of the coalitions we run, which focuses on everything on the intersection of healthcare and technology. So that's right for our conversation today on telehealth. And as April mentioned earlier, I will be giving some additional high-level information about what's happening in DC, what we expect going forward, and just an overall lay of the land, so where we can anticipate to be situated following the pandemic as we come out of this.
Well, if until April gets back on, I may go ahead and, in the interest of time. Oh, there she is. April, are you there? I see you. If y'all give us just a minute to see if
I am back. I'm so, can you hear me?
Yes.
Yeah.
Yes.
I'm so sorry. I don't know what happened. I got completely booted out. So hopefully you guys moved on. If not, if you could introduce yourselves at this time.
That's actually what we did. We took
okay, great. So Cheryl, why don't we move on, and why don't you give our attendees a bit of an update on sort of the historical perspective of how telehealth and telemedicine has existed in the long-term care setting, and then we'll move in and have a discussion about some of the exciting changes that have happened as a result of the federal and state laws.
Okay. Well, the issue of being able to have remote communications with patients has been in place for a number of years. The big issue has been getting paid for it, and also restrictions that exist from one jurisdiction to the other. I do want to make a couple of comments just at the beginning before I get into some of the historical components of this. But, and setting a context, one of the challenges when we define long-term care is that long-term care has many components. And as we begin to talk about the application of telehealth to long-term care, we have to recognize that the type of patients who are in these facilities will vary depending on whether we're talking about a nursing home, another type of long-term care facility. So the type of services required are very important to the process of how one sets up the services. Medicare has traditionally been a bit more restrictive, although in 2019 they did open up some of the restrictions, but Medicaid has generally been a bit more open. Prior to COVID, we basically had in a fee-for-service model of Medicare, distant providers or practitioners could provide a limited number of Part B services to an eligible beneficiary. But the issue had to do at that time with originating site versus the site where the care was actually being provided, the distant site. And although there were a fairly large number of providers who were capable or eligible to provide telehealth services, there were restrictions in the ability of the institutions to be able to reach out to them. And they had to meet certain other qualifications. The other thing that they had in place was that there was a limitation in the type of telehealth or telemedical communication, that it had to be an interactive audio and video telecommunication, allowing real-time communication as opposed to asynchronous or other types of communications such as just telephone consultations. The other thing that was a challenge is that when you had patients in the nursing homes and there were services provided, the only one who could bill for those services were the physicians. The facilities themselves, particularly if they were Medicare and of course Medicaid being oftentimes a co-participant in the coverage for services, those facilities were not able to recover any additional compensation. So for purposes of the old version of telehealth and under Medicare and Medicaid, frankly, as I said before, Medicaid has been a bit more open and probably because of it pays poorly and it wants increased access. But Medicare had restrictions that made it a lot more difficult for getting reimbursement to the facility. Now, if the facility was, an assisted living facility, there could be private pay arrangements set up. Again, that facility is on more of a fee-for-service or private pay basis for the most part, unless you have really good insurance. I would say that I want to comment on private insurance coverage. If some self-funded health plans would reimburse for certain components of services, and again, we have to differentiate between the facility and the provider. The bottom line is that usually it was the provider that was able to get paid and not the facility itself. So I think with that, I'm gonna step back because I have a lot of other things to talk about as we get into the other topics.
Sure. And Cheryl, I think you hit on what some of the important topics are as it relates to how the CARES Act and some of the lobbying efforts at the federal level and how that trickle down has occurred at the state level, how that has enhanced and improved the reimbursement model for our long-term healthcare centers. And so, Allie, did you want to address sort of at your end what changes have happened as a result of the federal efforts that have been successful and those that are in the works?
Right. Yeah, I'd be happy to. Thank you. It's interesting. I feel like we're, 25 minutes in and we've talked about the CARES Act and changes in DC, I think a handful of times already, which just goes to show the impact and the breadth of the changes that have been made. One thing I did want to know is we have seen changes at the congressional and administrative level, unlike I think we ever before. It's been dynamic, it's been nimble, it's been rapid, it's been extensive, and back to back to back. They passed 3 bills, in a matter of 6 weeks responding to this pandemic. It was unprecedented. And so I think one of the interesting things to note is they have been scratching rules, barriers, regulations to reimbursement, and then making it a lot more flexible left and right. The one thing to note, though, is that most of these authorizations are for a limited duration for the time of the public health emergency, which is great in some ways because it allows us to kind of have this period where we can really leverage telehealth for all of the opportunities and all of the benefits that it can provide if you don't have those barriers. But it also leaves an open question of what's going to happen at the end of the day once we start to work out of this. So just at a high level, some of the changes that have been made, some provider flexibilities have been enhanced. Folks are able, through a variety of waivers, regulatory changes, and federal guidance, able to practice across state lines more easily. We're getting some workforce issues addressed. Reimbursement has been increased, and there's been some of the restrictions that I think have already been mentioned, former restrictions on originating site or those sorts of things, or on the types of care provided via telehealth, or on the modality restrictions like not using audio only but allowing for audio visual. Those have been drawn back, and what's interesting is you can even see the difference in between the first coronavirus response bill and the third coronavirus response bill, and then the activities that have had them since. It's pretty extreme. The first bill still had a lot of those controls built in because that's been kind of institutional. It's been the history forever. As we've had telehealth, you've always had those controls, where you try to restrict and have, an existing relationship between a provider and a patient, or you require audiovisual. By the third bill, that was gone. You know, like they'd been lobbied so heavily, but also I think they were realizing this is a pandemic of such a scale that we can't have these barriers in place right now in order to be able to respond in the way that we need to. But again, going back to my earlier point, this is not the cure-all. This is not the new regime of telehealth for all of the years to come. This is just where we are in the public health emergency. And I don't know if I'm getting ahead of myself a little bit, but there is an open question about what is going to stay and what's going to snap back to the way it was. Because underlying all of this, right now we're triaging based on a pandemic, you know, based on an immediate need that overrides all other interests. But at the end of the day, we still have to pay for this.
Right.
And so what's the cost?
Yeah.
And that's something that we'll have to keep talking about, but weighs in heavily when we think about forecasting what policies are going to snap back and what's going to stay the same.
Right, and that's a good point that I think we're going to touch on. But before we move to another question, I wanted to sort of weigh in on this issue of how some trickle down has happened from both the federal level to at least the state level in Illinois. I'm not privy to how many of our attendees are operating and practicing within the state of Illinois, but Allie makes a good point that some of the restrictions that have been a deterrent to the delivery of telehealth across state lines have been due to state licensing. And there's been a bit of relaxation in the state of Illinois by virtue of our governor's executive order, his first one in March, which does lessen, it does not eliminate, but it does lessen some of the requirements as it relates to licensing of telehealth providers across state lines. Illinois is also part of a compact. And so Illinois is actually the power player in that compact, and that's helpful as well for the administration or the use of telehealth, telemedicine in these skilled nursing settings, but in other settings as well. With respect to issues of reimbursement, Allie, you touched on this, that it's not, it can't have a never end date because of the value. And so some of the issues that have been a stumbling block to the use of telemedicine or telehealth in the long-term care setting is this issue of reimbursement parity. And some of that has gone by the wayside where CMS has said, all are welcome, all are going to be paid at or around the same cost. We're not going to differentiate anymore between originating site or room and board costs and things like that. At the state level, there's also been some parity, not as much parity as we've seen at the federal level as it relates to Medicare recipients. But can Cheryl or Allie, can you touch on how this issue of parity has become, you know, sort of an important driving force for some of the efforts moving forward to maintain, at least at a certain level, some of these reimbursement models so that we can maintain sort of some of these higher level telehealth processes that are now entering into our skilled nursing facilities?
Well, I'll go ahead and make my comments first, and then Allie, you can correct me. But some of this is really just a general observation as to the way these services are reimbursed. I don't expect, and one of the gating issues for many long-term care facilities, particularly those that receive Medicare, is that they assume that the compensation that is paid is inclusive of whatever other services are required. That is, you know, many of these are cost-based in terms of their reporting. They're expected to incorporate, cover those services within the Medicare payment itself. Medicaid usually pays poorly, but in this case, Medicaid supplements the Medicare on some components of this. I think the parity issue is really on coverage and the ability for the facilities to get some recognition of additional dollars. Federally qualified health centers, for example, do get some additional money. And I know I'm going a little off topic from long-term care, but just to make a comparison between the two. And this is a time-limited issue, but this this dance between Medicare and Medicaid is going to have to be resolved in some manner that possibly from the federal level on down, because states really do control, subject to the waivers, what the reimbursement, how much they're going to, what they're going to cover, and how much money they're allocating. Mm-hmm. So it could be done in terms of funding, but it's a matter of whose pocket the funding is going into.
Yeah. And who's it coming from? Yeah.
Yeah. I figured that's a lead up for you, Allie.
Yeah, that's great. Yeah. I was going to make this a similar comment to what you just said, whereas parity is a complicated issue. It's very divisive and it is a lightning rod. So I will say that at the outset at the federal level, because you have very strong opinions on both sides. The other thing is when we say parity, we mean different things. As Cheryl pointed out, a lot of times people are talking about coverage parity, but there's also pay parity, where it's like, are you talking about the same rate as? For example, when you talk about modality differences is how I refer to using an audiovisual platform versus an audio only. There's been some changes made recently to talk about, you need reimbursed audio only at the same rate as audiovisual and other modalities for the time being, for the duration of the public health emergency, because not everybody has a smartphone. So not everybody can do audiovisual. And you don't want to incentivize providers to not help folks who can have a phone call only because they're getting pennies on the dollar and can't really afford to do that. And so that's been one of the conversations that's happened, and that's kind of same rate as pay parity. Coverage parity is all coverage that you cover things that are done via telemedicine, the same way as I would if somebody walks in the door. And so again, both of these are divisive issues, and I do think that it's a key area to watch when we're talking about things that might snap back when we're looking outside of the pandemic. The reason being the cost. When you talk about parity, you're locking in a rate. And there's a lot of arguments from whoever's paying for it that it actually disincentivizes the use of telemedicine or the investment in telemedicine if you can't actually lower the cost at the back end because you're requiring the same payment. So that's one side of the argument. The other side of the argument is it's the same care, it's the same thing, why are you paying me less? And so you get both of those, strong contingent on each side. And so that doesn't make it easy for Congress to authorize that permanently. And then you have CBO, which we haven't talked about yet. And I'll spare everybody the gory details of CBO scoring, but leave it to say CBO thinks telemedicine's really expensive already. And so if we also require pay parity on top of that, they're going to think it's more expensive. And it's just something to consider. And I wanted to flag it for folks. Don't assume that the rates that are in place now for the duration of the pandemic are going to stay in place following. They might, but there's going to be a battle before they do.
Right.
Allie, on the front lines, which is kind of where I consider you are, since you seem to be getting the data way quicker than we are, besides Mr. Parkinson, who had it fresh off the presses. What are you seeing for length of time that we can anticipate sort of these relaxation of both regulations and more of an evening out of the both coverage and reimbursement parity? I know we've talked about the quote, life of the pandemic, and there's not necessarily been a date certain that's been attached to that, at least as being publicized, but what would be some projections that you're seeing on your end?
Okay, I'm going to caveat, these are less projections and more pure guess, which is the best I can offer right now. What I will say, and I feel strong about this one, is these things aren't going to roll back over the summer. They can't, because we're expecting a second wave in the fall. Nobody's going to feel comfortable rolling these things back. Also, not great to roll these things back right before an election. That's another important piece of this puzzle. We have an election in November. When we're talking about the duration of the pandemic, it's a declared emergency. So that could change. And it depends a lot on who's in the White House, I think. Everybody has an interest in streamlining this and making it as easy as possible and making people happy and getting us, a nimble response to the pandemic. But it depends on what a second wave looks like. Do we have one? Is it going to happen, or is it hype for nothing? We'll just wait to see what happens. But that's going to have an impact into 2021. What it looks like 2021, I think, is the open question for me. How much longer do we have a declared public health emergency? Do we declare it until we have a vaccine,
Mm-hmm.
that's available for all people. We're looking at a couple years. And I know that when we had a prior conversation about this between the three of us, the latest date I've seen in legislation was 2024, for some reports and appropriations and things like that. That's a possibility. It would make it easier because so many of these waivers are dependent on federal authorization. And the other thing I'd mention is I don't think that the federal government can make any significant changes until all of the states are ready, because then they'd be undermining the state response. And a lot of the waivers that are in place dependent on federal authority and tied to the declaration of a public health emergency. So, it's like a spaghetti. You pull one string, you're moving something else.
Sure.
Well, I want to ask a question real quick, really for both of you, because it really becomes kind of a state-federal question, which is, we're in a crisis now. The cost associated with stabilizing and of also being able to continue new measures or more aggressive measures of compliance, infection control, screening, employee type activities. I guess my question is, and I know I'm not the person leading the panel, but I'm interested in hearing your thoughts, because I've been thinking about it, is how is that going to be baked into reimbursement to a facility that has historically already been underfunded, particularly those that are skilled nursing facilities. So I'm curious, because I see there's a burden on the state for carrying that. I don't know how it's done in Illinois, but I know, for example, in Texas, they actually have a finite limit on the total number of Medicaid beds that they will allow to operate in the state as a whole. Again, I live in in a state that sometimes doesn't think about the people themselves, but and that's just purely that's a quip. But I was just curious what your thoughts are on whether that is that is something that's going to have to be dealt with, but also who should bear the responsibility, and is that something that the federal government should pick up as part of their contribution?
And before we respond, Anne just piped in that we are at the end of our session, Cheryl. Oh. So what I'm going to do is, if there's time at the end of the entire presentation, we'll come back and address that issue. But Cheryl and Allie, I want to thank both of you. It has been a pleasure working on this panel with you. And I'm going to pass it on to Anne to introduce our next panel. If you guys could both mute and turn off video. Thank you.
Thank you so much, April, Sherry, and Allie. I am now going to switch seats so Laura Jeanette, my partner, can be on screen, and I'm going to turn it over to Jen Brewer as the moderator to introduce the next panel.
Thank you, Anne. Can everyone hear me? Great. Welcome to our session on telehealth in the long-term care setting. Our session is really on lessons learned from the front lines. I'm Jennifer Brewer. I'm a partner and an attorney at Faegre Drinker. I'm the vice chair of our healthcare practice. And I'm pleased to introduce our speakers today. I have with us today Alex Bardak, who is the Director of Public Policy and Advocacy at AMDA, the Society of Post-Acute and Long-Term Care Medicine. Alex is going to give us some insight on telehealth from the clinician perspective and a little bit on the policy side as well. We're going to hear from Amy Stewart, who is the Vice President of Curriculum Development at the American Association of Post-Acute Nursing. She's going to provide a little bit of the nursing perspective, the role of nurses and the need for outside assistance. We're going to hear from Dan Herbstman, who is the founder and CEO of Third Eye Health. Third Eye is the nation's largest post-acute telehealth provider and provides a telehealth platform and acute care services that allow for physician consults in nursing homes. And Dan's going to provide us with some insight on the role of the provider in the COVID-19 and post-COVID, maybe pre-COVID environment as well. And finally, we're going to hear from Laura Jeanette, a partner at Prangle+Schoonveld, Laura concentrates her practice on the defense of hospitals and long-term care facilities. And Laura's going to focus on from the professional liability perspective, talking about the risks of telemedicine use and how to mitigate them. With that, I'm going to turn this over to Alex, please.
Hi, everybody, and thanks for joining, and thank all of you for taking the time to be on the call. I know it's a tough and busy time right now, so I'm going to jump right in. As was mentioned, I work at AMDA, the Society for Post-Acute and Long-Term Care Medicine. Hopefully you are familiar with our organization. If you are not, really briefly, we represent, as was already stated, the medical directors, clinicians, and PAs, and really the clinical side of those who take care of patients and residents in skilled nursing facilities. Needless to say, this has been a challenging time for them and for the facilities as well, and a time when it is both necessary but also difficult to communicate. Therefore, telehealth has become such a vital role, given that clinicians, physicians, and nurse practitioners go to multiple facilities, and we found from Kirkland and in many other areas that they can be vectors of spread. And so telehealth becomes the only opportunity they may have to be able to continue to take care of patients and at the same time keep COVID away from the facility. So let me just jump in on some things that some of them were sort of alluded to already in the previous discussion, but let me go into some more specifics. It was sort of stated already that clinicians have been historically the ones that could bill for telehealth services. I will tell you, however, that that is a strong statement. The reality is that prior to COVID-19, a pandemic declaration, clinicians could only bill a subsequent care code in a facility, a physician visit, only once a month. And that is the only code that appeared on the telehealth list. We have been talking to CMS for quite a number of years about this to lift this restriction. And when the pandemic was declared, we immediately started talking to CMS to lift all restrictions on not just that visit, but all visits in the nursing facility. Of course, then there is an initial visit, there's a subsequent care visit, and there's a discharge visit. So CMS, by virtue of the 1135 waivers, this is actually not in legislation. These are all regulatory changes. So we're actually not in the CARES Act. They're all regulatory 1135 waiver changes authorized by CMS, and there are many documents online. So what they did was to eliminate that once a month restriction. They also added the initial visit and the discharge visit to the list of approved telehealth services. That means they are now being reimbursed by Medicare. Not only did they add the nursing home visits, they also added all others, such as assisted living. Those are all different codes. They're used, domiciliary and home codes are used for assisted living. All of those are now reimbursable. So that's one thing. The other thing they did is, in the past, when you billed a telehealth visit, you had to bill a telehealth code indicating that it's a telehealth visit, and it had a lower reimbursement rate. We were talking about parity. Well, in this case, you actually still bill and you use the site of service in which you are would have been providing the service. So in this case, a skilled nursing facility, and you are paid at the same rate as a face-to-face visit, which was an important change. They also eliminated the requirement that a nurse practitioner in a skilled nursing facility historically could not provide an initial visit. That is now also lifted, and a nurse practitioner could do an initial history and physical visit, which is a big change. This is a monumental change to some degree. Of course, it still must be done with the supervision of a physician. So there have been a number of those technical changes, and they were issued in what are known as blanket waivers. That means on a federal level, an individual nursing facility or an individual state does not have to apply to be eligible for those waivers. They are automatically applied to all of you, and you can use them. So you may have already seen this in your facilities. You may have already been working with your clinicians. Amy and Dan will talk about how this is actually working on the ground. The frontline clinicians that are in these facilities are paramount to this effort because they have to still be the telepresenters. They have to be there with the patients and the residents. And there's a number of other issues you can go into that we don't have time. But certainly if you have questions, my organization's AMDA has held a number of webinars on this issue. We have a webpage actually that's dedicated to this. So happy to answer any questions through the chat here. Or, if you want to email me afterwards, I've gotten a lot of questions and happy to answer them. Thank you.
Thanks, Alex. Amy, let's hear from you.
Yeah, thanks, Jennifer. And we've talked a little bit about reimbursement. We've talked about the waivers, and I want to talk about the nursing aspect. I work for APACN, which is the organization better known as ANAC and AADNS for those of you in the audience. But I want to talk about 4 key things for nursing from the nursing department, and that is policy, process, presenter, and documentation. So we have these waivers in place, and we need to use these to the best of our ability in the facility. So we need to have a policy in place, and that policy needs to be distributed so staff are aware what we need to do to initiate a telehealth visit, if you will. We need a process that is consistent so that each time we have a telehealth visit, it's consistently done with a telepresenter. Historically, these visits, physician visits, if you will, were done by the physician, often on their own. One of the challenges might be under telehealth is that you need a telepresenter. And that telepresenter really should be a nurse, someone who can hear what is being said, document what is being said, and have the ability to take an order right then and there from the visit. Then I want to talk a little bit about the documentation. You have to have a process in your facility to shore up your documentation, not only from the nurse that is, doing the visit with the teleprovider, but also from the physician or nurse practitioner or whomever is the telehealth provider. You have to have a mechanism in place to ensure that you're getting that documentation timely in the record. And again, I'm happy to answer any questions. We have heard from the front line that it can be challenging to have a telepresenter be a nurse, but picking the right nurse is really key to that too. Last thing I want to add is that you want to make sure that your telepresenter that is doing the telehealth visits has baseline clinical knowledge of the resident or patient, as well as is very well aware of the clinical changes that are going on so that they can articulate that to the provider.
Thanks, Amy. Dan, you want to tell us a little bit about your technology and what Third Eye can do to help?
That sounds great, Jen. Thanks so much for having me on the panel. Great. Hey, everyone. So to maybe give a little background, and I'll just pick up where Amy left off, was we provide Third Eye. I'm the CEO and co-founder of Third Eye Health. And we provide a combination of a telehealth platform that's really geared towards the skilled nursing facilities and assisted living areas, a little bit more broadly also in post-acute. And we also have our own physician group that we work really closely with. So we've been around really offering for about the last a little bit over 3 years now, a solution that is really geared to the skilled nursing facilities to help them use telehealth to reduce the need to hospitalize patients. And so pre-COVID, we were used by a lot of the larger national chains, large regional chains. And the big reason that kind of some of the panelists alluded to in the last panel was there was really no reimbursement for telehealth. There was some in rural areas and areas deemed telehealth eligible by Medicare. But for the most part, we really worked closely with those larger providers because they were able to pay a fee for our program, which would have our technology be in place, and then also have our physician delivering care, especially in the off hours and nights and weekends, and to supplement some of the work that the primary care physicians and nursing staff was doing. And then as we were talking about, then the 1135 waivers happened. We were able to now offer our solution much more broadly to groups where we're able to charge a much lower fee, just the cost of our technology platform. And then we're able to bill through our physician group our visits. And so the best way to think about it is within a skilled nursing facility, normally we have our system set up. There's usually a tablet or iPad at every nursing station. We depend, as Emmy was saying, fully on nurses to be our telepresenters. They go through a training program in how to deliver telehealth, how to work closely with physicians. And then our tech platform has gotten down to be just a one button push on a tablet. It connects with the electronic health record systems like point-click care and matrix care in the skilled nursing facility. And then it sends an alert out to a remote physician. And we see really two types of physicians using our technology. We try to work really closely with the primary care doctors who see patients in the skilled nursing facilities. So the medical directors, attending physicians will have our application on their own phones. They'll be able to do their normal rounding, check-in visits, other things. And now in the latest environment, they're able to bill for this. And we've seen a large increase as they're able to do this. And it's also so much harder for them, as we all know, to get into facilities today. So it's a great way for them to work with their patients. And then we offer our own virtual urgent care and emergent care team. So they're available whenever the facility wants them, but it's mostly on nights and weekends. And then when that button is hit, within 2 minutes, our doctor will respond. They're usually an emergency medicine physician or a hospitalist who are especially trained have gone through a program, our training program, so they really understand the post-acute patient. And they'll go ahead and provide a live video visit. They'll actually guide the nurse through an assessment. They'll have a discussion about the patient, and then they'll document that visit. There'll be a clinical note. And then we've developed a good care coordination model with nurse care coordinators that really hand care back the next day or after our doctors are off, back to the nursing facility, with the idea of creating this closed loop to really be able to hand care back and forth and continue to monitor the patient.
Thank you. So I see a question that maybe Dan or Amy could answer from the audience. The question is, how does the teleprovider document the encounter?
Yeah, I can start that, Amy, and then if you want to add to it. So yeah, from the remote telehealth provider, part of our system is we have our own electronic medical record geared to a telehealth provider. They document that note in the system. We have built an interface with Point-Click Care, Matrix Care, NetSmart, the three biggest electronic health records that will automatically go into the patient record. Depending on the system, it'll either look like a regular note in the record or just an attachment to that. We can also send an order through the system also, so that order also is generated and then becomes part of the patient record.
Thank you. And with that, yeah, Amy, did you want to add anything? Sorry, go ahead.
Yeah, the only thing I wanted to add is if your facility does not have technology that can receive that information, you must have a process in place, obviously, to ensure that it does get into a hard chart. You know, there is still some facilities out there that are using a hard chart of, the old clinical chart. So you have to have a mechanism in place to ensure that note gets in there after those visits.
Thank you.
I almost hate to say
Alex, I would just also want to clarify, because this gets confused all the time. When we say teleprovider, it is in my mind, it is extremely important to differentiate the clinician from the facility. So I'm actually not certain which we're talking about. If it's a clinician that's billing, then you document it as we talked about. If it's a facility, there is a code also that you can submit to as an originating site that was already talked about to get the payment for that. So it just, I'm not sure which one they were referring to.
Thanks for making that clarification. With that, I'm going to ask Laura to weigh in on some of the risks and how to avoid them in the telehealth environment.
Hi, I'm Laura Jeanette, and I'm a trial lawyer. I've been defending hospitals and skilled nursing facilities going back to 1986. So I'm going to get right to it. I think telehealth is a must in this climate where we're going to see wrongful death cases related to COVID. We know that there is currently a COVID task force that I'm involved with, and we believe uniformly that there's going to be a cascade of litigation related to these wrongful death cases, and that we need to brace for the impact of that litigation. So 15 states, we heard Mark say, have these promulgations, executive orders, and Illinois is one of those states. But there will be constitutional arguments related to the immunity. And in addition, there are carve-outs for cases where there will be no immunity. And those include gross negligence and willful and wanton conduct. So we know all the pleadings are going to come in stating that it was gross negligence or willful and wanton conduct. And so that's going to be in the eye of the beholder, and that's going to be our motion judges. So we can't count on the comfort of immunity provisions. We're either going to have to do motions to dismiss or affirmative defenses. And those are being prepared now along with discovery on these issues. So the usual suspects in nursing home cases are documentation and communication. And I'm going to talk about that as it relates to telehealth. So why telehealth? We know that there has to be a 72-hour visit after admission, and there has to be a visit at 30 days. And those are for the safety of the patient. So we need to have a vehicle to allow those visits to take place. And more importantly, I think, is the issue of forward triage. Now we have individuals with a condition that we're getting up to speed on a variety of different presentations in geriatric patients. That could be somebody that speaks 10 words, now goes down to speaking 3 words. So some of these changes in the elderly are very subtle. And so this forward triage, where you can get a nurse practitioner or a physician with eyes on the patient, helping with that decision about, is it in the best interest of the patient to go forward to the hospital setting, or is it not in their best interest? And there's a lot of issues that go into that, but we know that there are dangers for these elderly patients. So it's a technology that can help us keep the residents in the facility with some eyes on by a provider. Dan obviously is talking to you about a third-party provider like Third Eye. The only thing I'll say about that is that they're not all the same. Third Eye has a good reputation. There's due diligence that needs to be undertaken with third-party providers. And there's a cost element that you need to investigate. But telehealth doesn't have to occur through a third-party provider. It can take place on an iPhone or an iPad. Obviously, cleaning those in between uses is important. But, you know, the perfect can't be the enemy of the good as far as getting the telehealth up and running. And it's important when we talk about documentation that the telepresenter is documenting in the nursing home record that they were the person who was speaking to the teleprovider, and that that individual's name is also in the record. And so we need both as we go forward to understand who was part of that communication. I'm going to just say a few lawyer words for you of things that I want you to do. And that is to make sure you have a consent for the telehealth. And that can simply be the nurse documenting or the physician documenting that there was consent for the televisit. You also want to make sure that with all of your other COVID policies, that you have robust policies so they can see what you've been doing in this climate to deal with all these issues. And we know we have allegations of scarce resources, and now we're going to not only have allegations related to staff, but related to the PPE. So we have to make sure that we're using resources that we have, like telehealth, to help get appropriate communication with our patients when we have the providers. As Dr. Fauci says, we want to lock the doors and keep all the people that can spread the disease out, but we still have to provide a vehicle for communication with these providers. And also, I think one of the things that's important is to keep track of that timeline as far as all the regulations. There is a toolkit for telehealth, and it got a lot of useful information, great articles. But after that toolkit, we see rules that have changed and promulgations and bulletins. And I would just draw your attention to the March 28th, 2020 Civil Rights HIPAA bulletin. It has a lot of good information about telehealth in there. And so I know from my own clients, it feels like this is one more thing. You know, now we have to do one more thing. We have to figure out telehealth. And what I say to them is that that effort of just getting it up and starting and getting it running, and like Amy says, get a process in place, make sure that the person who's the telepresenter has baseline information about the patient, because that's the useful information that the teleprovider is going to need. So I've heard, you know, get an activities aid doing it, and I strongly suggest against having somebody that's not a nurse provider, as Amy indicated. So there's a lot of issues here, but there's fines that are going to be coming at us. There's the costs of this litigation and the cost of payouts if we have not documented that we're using the resources that we have to connect the residents in the facility with the providers. Thanks.
Thank you, everyone. I think we are about out of time. There's one question that I'll just pose to the group that was asked. Are dictation of the teleprovider visits sufficient without a telepresenter? Can anyone answer that, or we can get back to it offline?
I mean, this is Alex again. I think and I think I answered a question similar to that. Again, I think as was just stated very well, you have to be able to document the visit as if you did a face-to-face visit. CMS has made this very, very clear. The documentation requirements for visits have not changed. So whatever you would have done face-to-face, do it there. You have to, I didn't cover this, but you have to use the modifier 95, not your normal telehealth modifier, and that will indicate to them that you did a telehealth visit. But all the requirements around spending time, medical decision-making, and all of that have not gone anywhere. So make sure you're doing that. And I think what you just heard about the legal aspects of this, even more so, because this will be looked at very, very carefully. Were visits conducted? What type of visits? Was everything done to prevent the spread in terms of PPE? If a telehealth was available, was it done? So all of that you have to be very mindful of.
Thank you very much. And thanks to all of you for participating in this panel. And I'm going to turn it back to Ann, I believe.
Thank you, Jen, and thanks to all of you on the panel. I am going to introduce our last speaker. To close out our virtual forum, I have the pleasure of interviewing Dr. Thomas Lally, who is the founder and CEO of Bloom Health. Bloom Health is an employee-owned primary care practice that supports and treats seniors in their homes. Dr. Lally joins us to share his thoughts about the future of telehealth in long-term care beyond this pandemic. A little bit of background on Dr. Lally before I start asking him some questions. He's a house call physician with a passion for ways to take care of our community's most vulnerable patients. He's a national leader on the treatment of dementia, providing instruction to providers as well as educating the greater community. In 2014, he was named Physician of the Year by the American Academy of Home Care Medicine. Dr. Lally, thank you for being with us today on this really important topic.
Thanks, Ann.
My first question for you is, if you could please share your experience with telehealth long-term care in the COVID-19 pandemic, which I presume, at least in part, forms the basis of your views on what's to come with telehealth and long-term care.
Really, just a little bit of background. We are a kind of comprehensive primary care practice that was using population health, and we were agnostic of site of service. So we would do house calls, assisted living, long-term skilled, but we really wanted to take this population who we said was the sickest 5% and be very proactive with their care and delivery. Then COVID hit, and we really got caught off guard. We were somewhat fortunate to be able to have some of the systems in place to be able to kind of shift rapidly. So here we are, more of a post-acute provider for the sickest of the sick. Our average age was 88 years old, and agnostic of site of service. But I would say the most important thing for us to really get started in telehealth was really the fact that we were very proactive in how we thought about healthcare in the first place. We were thinking about supply and demand of what our patient might be needing. And so we were we're really looking for those factors to kind of shift the demand. And we saw that once they waived some of the restrictions around two-way video, HIPAA restrictions, some of the payment reforms, we immediately got on as fast as possible to try to prevent infection of the spread for our patients and for our providers. I think it was probably 5 days into it before we realized that one of the biggest problems was going to be telepresenters and being able to have sustained response for them. And we, being somewhat agnostic to site of service, we are in both assisted living communities who might not have a nurse. And so I know it might be best just to have a nurse as a telepresenter, but we might be really kind of get the telepresenter. And so within the first week, we started seeing challenges there. Scheduling patients, trying to make sure that we were able to get, those things aligned and synchronized between the provider's available time and the telepresenter, really prepared for those visits ahead of time, and doing a lot of the follow-up calls afterwards to make sure that we didn't have any sort of difficulty with communication or taking more time from the telepresenter than we needed to. And devices. We went out and bought a lot of devices very quickly. All of our providers already had a couple of 4G devices that were company owned, but we had to then buy more devices and get these inside of the communities and facilities who were trying to help with the telepresentation, but really didn't have any ability to be able to broadcast that, internet signal. I'd say the reception has been very mixed. Among providers, patients, and quite frankly, communities and facilities. Our providers, we've got a group that said, yes, this is awesome. I really like it. I like engaging with my patients and kind of having longer conversations potentially with the family. There's a big in the kind of the maybe skeptical and wants to get out in the field. And there's a group about 25 or 30% when we post that really say, hey, telepresenting is not for me. I want to get back out in the field as soon as possible. See somewhat of a similar breakdown among the patients. And again, we care for a lot of patients. About 50% of them have some cognitive issues. So that's going to be an added challenge, but it's really difficult for some of those patients to connect with the provider on the outside. And communities and facilities, we see a big discrepancy between the early adopters and some of the people who are saying, hey, this is extra time out of my day. I'm not required to do this. Who's going to pay me to do it? And I would say that in the current state, it's still somewhat, in my mind, of a mixed sustainability. We haven't figured out some of these things that are going to make it long-term sustainable. And I'd say one of the most important for me is really an aligned incentive for the telepresenter across a wide variety of groups. I think inside of the skilled nursing facilities, we don't really have much of a problem. They have a lot of skin in the game. As we go down the levels of complexity and get into the assisted livings, there's just not as much alignment. Figuring out that fair market value and the reimbursement and who we pay to do that telepresenting as an organization, the telepresenter themselves. In some of those situations, it'll be different. And the devices, those are devices today. They are because we need to rapidly deploy them from the provider side. But eventually, we'd see some of those potentially being owned or operated by the facilities more. And really all the insurance best practices and training around this, it really hasn't been established yet, although we're trying to put it together real time and make sure that we can go out there and say that, hey, if you're going to be doing this, we're doing it with certain protocols that might change and improve over time, but we're taking infection control, we're taking best practices into consideration, we're making sure that we're not being that nidus of infection between rooms.
You talked a little bit about assisted living facilities, and that brings up a topic, not just assisted living facilities, but other facilities where long-term care residents or patients might exist. Can you talk a little bit about that transition of care and how telehealth could be a tool or how that might play into the transition of care from acute to post-acute, or from one type of post-acute to another setting?
I think it's critical, and it gives us much better decision making, both on the exit from a facility saying, hey, Mrs. Smith might be really sick today. We can do a telepresentation right now, really get a good picture of her, capture that visit, and then prepare a plan. It's just more effective than the on-call phone call only. And we're able to hopefully use that telepresenter on the other side. So today we're staffing 2 special isolation units inside of skilled nursing facilities. And these are really intensive skilled nursing facilities where we have 5 to 7 day a week, provider on coverage for multiple hours a day to handle both the admissions, discharges, and a lot of the decisions that need to be made. But behind the scenes, we have 24/7 access to virtual visits. Our providers who are normally on call, instead of just picking up the phone, we're trying to do as many virtual visits, especially in these isolation units where it's aggregated and sicker. About 50% of these patients are kind of in more of a recuperative rehabilitation stage, and about 50% of them are actually still really sick. With variable goals, some of them are going to go on to the hospital if things get worse, but they're sick and they're taking very active management. And these patients are generally coming from two sites of service. So they're either coming from a hospital setting where they're kind of depressuring the hospital and we're moving them to a congregated setting where we can provide a safe support, and then hopefully, with the test-based strategy, get them back to their original home. Or we're doing direct admissions, and it's about 50-50. And really the direct admissions are coming from our testing efforts inside of our assisted livings, inside of some of the patients' private homes, where we identify a patient who can't be cohorted. We need to get them out to a unit right away. And the moment they're getting in there, we're able to provide a physician level visit. So we don't have to wait the 72 hours. We've got providers on call all the time. If we can get a telepresenter upon admission, we can actually get things, squared away, some of those important phone calls and a plan of action much quicker.
Thank you. I think some of the other panelists might have touched on the topic of safety, but definitely when you and I talked in anticipation of this webinar, one of the themes that I heard you talk about was safety being paramount and how telehealth is a tool to provide safe care to residents. Can you elaborate on that?
It's an excellent question, and it was one of the real early priorities that we had. And we were thinking about it, somebody said it earlier, it's patients and employees and frontline caregivers. If you don't protect all three, you can't keep doing this work. It was actually fairly easy in March to make an executive level decision to say, hey, we're doing as many telehealths as possible. We're just going to kind of make this retreat. We had the platforms and systems that we were able to stay very productive during that time. But it was much more difficult over those coming days and weeks to be able to make a measured approach back into the field, figure out when it's appropriate to do telehealth and when it's appropriate to not do telehealth. And it wasn't long before we had our list of challenges, and whether they had no access to care because the telepresenter wasn't there or available, whether the patient just needed a procedure, a more in-depth look for diagnostics, et cetera. A big use of our live visits today is still testing. We're out there testing a lot of people. And, when we cohort patients, we can't do televisits all the time. We want to be out there live. So in special isolation units, we still are, out there properly PPE'd and live. But we had to develop a safety committee and an algorithm to figure out how to do these televisits correctly, when to do televisits and when to escalate to maybe a live visit with the proper protection. It's been a process, and it's not easy to kind of go through all these different scenarios. Our patients, come at us in a lot of different ways. And sure, you can go in and maybe doorway round as your own telepresenter and be fairly low impact from a risk standpoint. But when you're going up close and personal and you're touching a patient and having to clean yourself going back into another patient room, the risk becomes, astronomically higher. And really having telehealth as the majority of your visits when you don't have to touch a patient, I think it's going to be mandatory. And I think not only from a clinical standpoint, but certainly from eventually a legal standpoint, there's going to be liability for people who don't figure this out. And so really going through with a thoughtful process. And, we're documenting and saving and then revising. And it's something that's a continual process as we learn more inside of these units, inside of some of the facilities where we get sustainable telepresenting done well.
So kind of the key question here, the future. What's your vision based on the experience you've had both pre and during COVID with telehealth and providing care to residents in long-term care settings? What's it look like for telehealth in long-term care in a year, 3 years, 5 years? I think 5 years we're talking about, no one can envision what changes are going to be here in 5 years in healthcare because it changes so rapidly. But tell us what your thoughts are on the future.
Sure, and it's an excellent kind of look into the future. If we just look into the past 3 months, we've made a couple of points on today's call about the rapid response and legislation from Washington and the rapid implementation of, and really understanding how to go out and do this. Year one is going to be a very active phase. I think that we're going to still be kind of trying to figure this out. I think there's going to be a lot of areas of the country where there's going to be a lot of activity of the virus, other areas where there potentially will be less. So the supply and demand of televisits is probably going to be variable among our different geographies. I also think that there's a lot of reasons that it won't be sustainable at levels higher than about 60 to 70% of the visits being televisits. And I think that there's a difficulty in scheduling these telepresenters. We've seen it ourselves. We've seen a tremendous amount of building stress where most of the facilities and communities have about 40 to 50% staffing on a good day after a COVID outbreak. And then when you put them in PPE and you ask them to do all of the extra policies and procedures, there's just quite frankly not enough time in the day or enough people in the building to make some of this stuff sustainable. And we're going to have to figure that out. I think access to new patients is a real problem. We look at it, on a daily basis from a KPI standpoint, but really there's a lot of patients who are kind of withdrawing from care, and we see other providers going out there trying to be more alive. We think that's the wrong thing to do, but there is a certain pressure and competitive considerations have put some provider groups into saying, hey, we're going to go out there and start seeing live patients because they think it's a chance to grow. So there's a lot of things that have to be weighed out in year one. We think that there's a lot of things that haven't been discovered, but year one, I think, is going to be somewhere where it's a little bit of the Wild West, and things are going to be implemented somewhat haphazardly, probably in the first year. When you get to year three, I think it's going to be more interesting because I think a lot of the regulations will have caught up. We certainly make sure that this is sustainable. We certainly need to make sure that it's compliant with HIPAA policy. We need to make sure that the patients on the other side, who are the telepresenters on the other side, have a business associate agreement with us, especially in these assisted livings, that we have strong liability controls, insurance controls. Who owns those devices? Who maintains the devices? Who even integrates those devices with, either on-site EMRs like Point Get Clear or the provider's health record like an EMR? We think that that's a lot of unanswered questions there. We talked somewhat earlier about reimbursement and who drops the bills for these codes. Well, that's not the same person as who's doing the work anymore. And I think we have to think about sustainability, fair market value, and saying that there's got to be some sort of long-term process to be able to allow the people who are telepresenting for us to also, be reimbursed either at an organization level or at a personal level. I think by year three, we're going to see a lot of revision in these rules allowing, people to go over state lines and to be able to process and help provide care. But I think it's going to provide some competitive considerations and opportunities for operators inside of long-term care. And certainly more potentially competition for providers inside of long-term care. If you're not doing a good job and I can provide a virtual solution inside of a building, people are going to be looking for that. And I think that there's going to be somewhat of a discrepancy by year three of the adoption on the fee-for-service side versus the people who are doing value-based care. We know that even in the past, there's been a lot of ingenuity allowed inside of value-based contracts. It's one of the reasons we were using population health and trying to be more innovative for our 88-year-old. We know they cost a lot of money, and we know we can take that money and deploy it in potentially a higher value method than driving out and trying to drop fee-for-service bills. So fee-for-service adoption, I think, is going to be a little bit different, but I think we're going to see rapid adoption within some of the people who can be more innovative inside of value-based contracting. By year five, I tried to write some stuff down because I agree with you, and it's really getting out there. But I was trying to think about it. There's certain things that I think we can make. It's going to be a cemented market demand. There's going to be an expectation from patients' families, from patients residing in there, from communities, quite frankly, from our providers, that this is part of the package of care. Once it's in the toolbox, it's really hard to kind of pull that out. And we know properly applied, it can be done well, especially nights, weekends, some of these times for specialty visits when you just can't get out there and do it any other way in somewhat of a sustainable fashion. We think there's going to be really the second generation of solutions. There's going to be a rapid number of people who kind of deploy solutions between years 1 and 4, but by years 5, we're going to be seeing second generation where there's two-way video. Vital signs will be potentially beamed from across the room as much as possible. We're going to be able to have some diagnostics built into there and probably a self-cleaning UV light. I can see situations where this thing drives around like a Roomba and basically doesn't need the same sort of telepresenting and can do it with, kind of self-cleaning and maybe even self-maintenance. Who owns it, who deploys it, and so forth. Haven't figured that out, but I do think it's going to be a pretty exciting future and allowing us to be able to respond to some of these really high-risk patients, get some of that specialty care to patients who don't have it today. And certainly if there's any infection control, whether it's a pandemic or flu outbreak, C. diff, or anything else that's going on, this allows us to get into that room potentially much cleaner with less risk of infection. So I'm actually kind of excited to see what comes out. I know there's going to be a lot of innovation in the area.
Thanks so much, Dr. Lally. We are getting close to the end of our time, but I appreciate you ending us on a pretty high note and a positive note as it relates to telehealth and long-term care. I want to turn it over now to Becky Sanders of Upper Midwest Telehealth, and then we'll close with Nancy Kazak from Partnership for Connected Illinois. Thank you so much.
Thank you so much, Anne. This has been a wealth of information today. There's so much information to digest and all the changes. You guys did an awesome job covering everything. I'm honored to be able to facilitate this webinar for you today. And I just wanted to remind our attendees, we have recorded today's session. We will be posting it on the UMTRC archived webinars webpage, and as well as any of the slides that were presented today. We will send that out via email to the email you used to register for today's event. And you will also receive a link to a SurveyMonkey to provide some feedback for us on today's event in that same email. And at this point, I'm going to hand it back to Nancy Kazak to wrap things up for the day.
Thank you so much, Becky. I want to thank all the speakers. The speakers were extraordinary, and I really appreciate all the time and effort that has gone into your presentation today. I want to thank again Hall Prangle+Schoonveld for coordinating today's program, and for Upper Midwest Telehealth Resource Center, not only being there for today, but being there for the last 5 to 10 years, keeping this all moving in the Upper Midwest. I want to thank our supporting nonprofit organizations who help publicize this event: Chicagoland Healthcare Risk Management Society, eHealth Initiative, Illinois Association of Healthcare Attorneys, Illinois Primary Healthcare Association, and Illinois Rural Healthcare Association. We really appreciate all your help. And we appreciate all of you for participating in this. We will be having continuing in our series on various aspects of telehealth and the pandemic. So look forward to getting some emails from us notifying you of the latest things that are going on. And I also want to give a special thanks to all those frontline healthcare providers who are keeping us safe, and we really appreciate you. But thank you so much. Have a good afternoon.